So I'd like to thank the organizers and my friends now for inviting me again to this meeting. It's been very nice and a pleasure being here. So I'm going to be talking about radiotherapy and the direction there's some opportunities where we can use particle therapy, which is becoming a new technology that's becoming a little bit more available worldwide, and some ideas about how we might best use this for our CNS tumors.
There's another one.
No?
Después tenemos 10 minutitos de preguntas, así que les recomiendo que vayan haciéndolas para agilizar después.
Quieto, ya está pasando.
Pero ya no.
Por favor, les ruego que detengan el tiempo, porque le quedan 16 minutos de acuerdo con esto y la doctora no ha podido iniciar la charla. No sé si eso se puede hacer.
So sorry about that. So what are the theoretical advantages of why particle therapy might be of use to patients with brain tumors? There may be increased conformality. There may be decreased integral dose, meaning that the rest of the body and the rest of the brain may receive less radiation. So therefore, you may be able to deliver the equivalent amount of biologically effective dose with fewer toxicities. And there may be, just in general, reduced toxicities, and especially in patients who are very vulnerable, the children and people who are going to survive their tumors. The possible disadvantages are the unknowns. Is there an increased neutron dose for proton therapy? Are patients going to be more susceptible to set up uncertainties where the change in dosimetry may be affected? And of course, there's the cost of these facilities. So particle therapy for CNS tumors, there's very few patients that have been treated outside of the skull base. And so that is something that we still have to worry about and think about. There's very few prospective trials, virtually no randomized trials, and there's a few. And then the endpoints that we may be interested in for these patients, such as neurocognitive outcomes or toxicities, neuroendocrine outcomes, are only achieved after many years. So it's very difficult to validate the role of particle therapy for side effects that may happen a decade down the road. So these are all the things that are current challenges. So we have a lot of dosimetric studies. If you look in the published literature, there are many publications looking at that proton dose is better than IMRT dose, that is better than 3D conformal dose. And all of the studies suggest that proton therapy or neutron or carbon therapy, which is less common, is equivalent to IMRT, stereotactic techniques, and there's potentially better normal tissue sparing. So that's really our foundation. And IMPT, which is an intensity modulated proton therapy, using the same type of principles for IMRT, may even improve the conformality and homogeneity compared to other proton techniques. So this is the direction that there's a lot of literature in, and we feel quite confident in that. So this is a typical dosimetric study that you will find out in the published literature. You'll have all of the technologies and the same tumor, 3D conformal, stereotactic, fractionated, IMRT, and then within the proton environment, you'll have the spot scanning or the passive scatter, or the scanning beam or the pencil beam. And generally what you will see is the drop of the normal doses in, let's see, in the area of the low dose, and whereas you're delivering the same amount of radiation in the high dose area. So this suggests that we can reduce the dose to the normal tissues, therefore reducing toxicities. So what are the tumors that have been treated with clinical series that have been published? There's been experience with meningiomas, craniopharyngiomas, acoustic neuromas, pituitary adenomas, AVMs, and some glioma studies. So a large number of benign tumors and a few malignant tumors. So this is a meningioma experience, and you can see that in this skull-based, very low meningioma right at the foramen magnum, that the radiation dose is being delivered to the target, and there's less dose given to the rest of the brain. The brain stem will still receive some irradiation, and we need to be aware of that. And the cranial nerves in that area will receive some radiation, and we have to be aware of that. But in general, the rest of the brain is getting less radiation, so maybe in this patient, there'd be fewer toxicities. This is a summary slide for proton therapy experience for meningiomas. The number of patients, and most of them are 20 to 30 patients. There's one experience from Noel, which had 51 patients. The dose that was given in that study is much higher than we give for many of our benign meningiomas. They gave 60 gray. In proton therapy, it's cobalt gray equivalent or gray equivalent, which takes into account the small difference of biologic effect that is noted with proton therapy versus X-rays. But across the board, you can see that the results are quite good. They're comparable to what we would expect for benign for photon irradiation, and toxicities are quite acceptable. You might see the one publication from Wenkel, which had 8 out of 46 with severe toxicities, and this was a combination of both protons and X-rays. But in that experience, it was a little bit older. There's newer technologies that have been incorporated. So hopefully, this will decrease as we're incorporating the better technologies for delivery and for delineation of the tumors. So for meningiomas, there's certainly no reason not to use particle therapy, and in this particular series, proton therapy, with or without X-rays. But what we need to see is what's the benefit. Functional outcomes for benign meningiomas, and this is from the Noel study looking at X-rays and protons. They had 51 patients. It's an old series from 1994 to 2002. Their dose again was 60 gray. And of the 108 patients with eye symptoms at baseline, 69% had improvement between 1 and 2 years. So that's actually very good. There was improvement of proptosis, palsies, diplopia, and ptosis. So there was some improvement in their cranial neuropathies, which is also nice and it's optimistic. 81 other symptoms of non-eye, including headache, trigeminal neuralgia, palsy, motor disturbance, vertigo, and 12th nerve palsies also improved in a large number of patients. So there seems to be some benefit in clinical outcomes, but this does not say that the addition of particle therapy was better, but it shows that we can actually give some information to our patients. In craniopharyngioma, again, a small number of patients treated with small publications. This is 15 patients in each study, and local control, again, was very good, 85 to 90%. And the late toxicities that were experienced in these were as expected. I think going forward for craniopharyngioma, this is something that we're very interested in, is that we're able to spare the hippocampus, which was spoken about in the previous experiences and the previous lectures, where the hippocampus may translate, reduction in dose to the hippocampus may translate to reduction in dose in neurocognitive outcomes, and especially in the young patients. Acoustic neuroma, this is our experience from the Mass General. The Massachusetts General Hospital, one of the pioneers for particle therapy, and a lot of the information that we have that we use going forward is based on their experience. So they did stereotactic proton radiosurgery, and there were 68 patients treated in the 1990s. The mean volume was small. These were selected patients with 2.49 cc's. And they gave 12 gray to the 70% isodose line. That's similar to what a person might do with gamma knife radiosurgery. The median follow-up at that time was 34 months. Local control was very good, 94%, and 5-year local control was 84%. So this was also very good. So clinical outcome, there were some toxicities. 3 required a shunt placement, presumably because there was swelling and compression of the fourth ventricle. 4 out of 6, the hearing worsened, which is not unexpected. The tinnitus was not changed in 13 patients. In 2 patients, it was worse. There was 3 patients with severe 7th nerve palsies, which is something that we need to look at. And there was 9 patients with mild 5th nerve palsies. So again, stereotactic proton radiosurgery for this group is possible. Very few groups are doing stereotactic particles radiotherapy, but this is something that we could incorporate. Pituitary tumors, again, from Mass General, their experience showed with proton radiosurgery, older experience again, acromegaly, 22 patients, 60% of those patients were off of medications at 6 years. So this shows how long we have to follow these patients to really look at their outcomes. For the Cushing's disease, control was 100% in those patients with Nelson's, and half the patients with Cushing's disease had control. Fractionated proton therapy was an experience was published by Ronson at Loma Linda. There was 47 patients, and of those, again, 100% hormone control in secreting tumors, and hormone control was 19 out of 21 in secreting tumors, and the 2 that did not achieve control actually ended up dying. So they must have had very aggressive tumors. There was 1 necrosis of the temporal tip, and 7 patients had new visual changes, and 11 patients had new hormonal deficiencies. So the toxicities that I would look at very carefully, there are the visual changes to make sure that they're acceptable, using, again, modern techniques, delivery techniques, and visualization techniques. So this is the experience for tumor control, for hormonal control, and for causing further hormonal problems. And you can see that these things take time, 5 years. So we have to be very patient when we're looking at patients with pituitary tumors and their outcomes, and we need the endocrinologist to control this. And this is really not very different than what we would have experienced for X-rays. So in glioma, this is an interesting experience. There have been 2 prospective trials that have been published for glioblastoma with aggressive dose escalation. So the point where particles have been used historically is to actually increase the amount of radiation being delivered to the tumors, and to try and see if the extra dose will confer a survival advantage. So Mass General, again, did a trial, a prospective trial from 1992 to 1996. They used 3D planning, and that is what was available at that time, and the 3D planning at that time was quite good. They increased the dose to 90 gray. Again, the cobalt gray equivalent can be translated to gray. And what they did is that when it came to that boost time, they gave a BID regimen, so twice a day. And protons were given for 33% of the dose. So in their experience, at least 50 gray was given with photons, and then the rest was given with protons. The median survival in this group was 20 months, which is quite good given the time that this treatment was done in the 1990s. 2-year overall survival was 34%, 3-year overall survival was 18%. So these patients actually did quite well, and I'd say that they almost matched the experience that the Stoop study that we all are familiar with. There was a high incidence of steroid use, and over half of the patients had surgery after radiotherapy. This is an example of the type of necrosis that was experienced in the high-dose area. Sorry for the image quality, but you can see that within the high-dose area there was a large amount of necrosis, and there was a need for surgery to deal with the necrosis. But interestingly, those patients with necrosis didn't continue to have a reasonable survival if the necrosis was managed with steroids and surgery. So carbon ion for glioblastoma, that's another experience that the Japanese have experimented with. And this is in the lab, and there's a suggestion that glioblastoma and gliosarcoma cell lines might be more sensitive to carbon ions than they are to X-rays. And so this is a therapeutic window where they have been exploring. They did a trial from 1994 to 2002 with 48 patients. They had both high-grade gliomas, anaplastic astrocytomas, and glioblastomas. And again, they gave 50 gray with X-rays, and then they escalated the boost using a carbon approach up to 24.8 CGE or gray equivalent in 8 fractions. So they used hypofractionation, which interestingly is less affected by carbon therapy because of the radiobiology of carbon, as well as a dose increase. They also gave concurrent chemotherapy. The median survival for this group was glioblastoma with 17 months, which is a little bit higher than we would have expected. There was no grade 3 acute reactions, and they had 8 grade 2 late reactions. So this is their experience with the anaplastic astrocytomas and glioblastomas on the left-hand side, and on the right-hand side, they looked at the dose delivery, and on the right, the graph on the right shows that the high dose actually conferred a better outcome. So their conclusion was that possibly giving a carbon dose to a higher dose total would lead to a better overall survival in these patients. So right now there's a lot of interest in the United States and Europe about how best to use particle therapy for gliomas. There are 3 trials that are actually ongoing or being planned. There's a Cleopatra trial that's being performed out of Heidelberg in Germany, and they're using 50 gray photons plus a boost of carbon, sort of like what has been done in Japan. And the results of that are not known, but the early outcome studies suggest that there's no significant toxicities at this point in time. At Anderson, we just started a trial 2 months ago now, looking at intensity-modulated proton therapy versus intensity-modulated X-ray therapy. We're selecting out patients who may have a better prognosis, and we're looking at neurocognitive outcomes. And this is really a proof of principle trial. It's a small study, and we're seeing what we can achieve with selected patients. And RTOG, there's a planned study looking at photons versus protons with dose escalation using protons for the boost, or there's a simultaneous integrated boost approach. It's going to be a very interesting study, and it's actually going through the authorities right now to see if it can get passed. So conventional versus high-dose retrospective review. This is just in general looking at the Japanese data again, and then their multivariate analysis, they showed that the performance status, RPA class, and high versus low-dose radiotherapy made a difference in this patient cohort. So it does show that maybe giving extra dose with particles confers an overall survival benefit. So this is something that we need to look at more carefully, but it is a way of approaching this problem. So for spinal tumors, I'll go through this quickly because I think I'm running out of time. But looking at spinal tumors in general, there's been a lot of experience for spinal chordomas, which is a rare entity, but it does require a high dose of radiation. So particle therapy might be able to deliver the adequate dose of radiation without treating the bowel or the pelvic structures that are within the pelvic cavity. The carbon experience has also shown that it's acceptable with toxicities. And here you can see the clinical results of a patient who is treated with a sacral chordoma. In panel A, the patient is prone, and you can see the area that was delivered with carbon therapy. And then for B, C, and D, these are the follow-up studies, and the patient is now supine, and you can see that the tumor actually shrank, but it took several years for the tumor to shrink. So this is a nice application for particle therapy where you want to deliver a high dose of radiotherapy close to critical structures. In the Mass General experience, they've had local control for 16 primary and 11 recurrent tumors. In 12 out of 14, if you're treated in primary situations, and it's the control rates for recurrent tumors is less. So it seems to me that if we are going to use appropriate radiotherapy or aggressive radiotherapy management for sacral tumors, it might be best to use it up front in the primary situation and don't wait for these tumors to recur. So setup is very, very important for particle therapy. In general, if you have metal in the environment, it can cause artifacts and cause dose heterogeneity. So you have to have a very good conversation with the surgeons to understand where the metal is. Try and do the planning in advance so that you can actually incorporate the issues that are that become a problem for particle therapy with the surgeons in advance. There's a high dose gradient, so we have to make sure that the patient setup is perfect from one day to the next. So if we're talking about delivering a high dose of radiation right around the spinal cord, you want to make sure that that patient is being set up to sub-millimeter accuracy on a daily basis. Intrinsic spinal cord tumors, just this brief word, there really does not seem to be an opportunity to really deliver a higher dose or a more effective dose to the spinal cord tumor itself, but there may be an advantage to sparing tissues around it. So if you have a spinal ependymoma or a low-grade glioma of the spinal cord, you can use particle therapy to reduce dose to the lung or the heart, the esophagus, the bowels, whatever may be nearby. This is particles with IMRT. There have been studies that looking at combination of X-rays and protons, X-rays and carbon, and I've referred to those in the past. One of the issues in the past was that availability of the particle machines was only once or twice a week, or it might be that they were only available three times a week or 4 times a week. So a lot of the older studies did incorporate X-rays as part of it, but strategically, sometimes a combination of both the particles and X-rays may actually be a good way to go. This is a patient with a patient that we've treated who had a 72-year-old man with a C-spine chordoma, and we were able to deliver 70.2 gray to the tumor, and we used both X-rays and protons to their best advantage. Going forward, I think we're going to need to use this approach less, because with IMPT, we're going to be able to get a much more conformal dose to a U-shaped target. So in summary, there's very little prospective data on the benefit of particle therapy for adult CNS diseases. There's theoretical advantages, but we still have to continue to collect that and then compare it to the appropriate X-ray experiences or do randomized studies, which are going to be quite challenging. All of the dosimetric studies that are available suggest a reduction in normal tissue doses. So this is something that we clearly understand, and it is something that we have to think about and have to think about what sort of endpoints we're going to be looking at to confirm this advantage. We need to collect more data to determine the benefit on mature nervous tissue. Children, it's clear that anything that's growing and developing, reduction in dose will be useful, but in adults it's less clear, and that's something that we have to continue to look at. Better functional imaging and testing should be incorporated in follow-up so that we can actually really look at what's going on at a level that we don't usually look at in follow-up. Neurocognitive testing has to go beyond mini-mental status. It has to really look at that fine-tuned assessment that only our neuropsychologists can do. Endocrine testing is the same. So it is something that we have to really look at what we're measuring. And dosimetric benefit is suggested for vertebral tumors that require a higher given dose. So chordomas, chondrosarcomas, spinal cord, or vertebral body sarcomas would all potentially benefit from particle therapy. And then the retrospective studies do show that the sacral chordomas seem to be treated quite well with particles. Thank you.